Thanks. All right, so welcome everyone. We have a lot of people here today. I just wanted to, before we get started with Ariel, our speaker, I wanted to talk a little bit about Manhattan Psychology Group. To give you guys a little info, we're going to have a survey at the end of this. There will be a link in the chat, so stay tuned and stay till the end so that you have access to the link to the survey. You'll need that in order to get your CEU. Throughout the webinar, there will be some code words that you'll also need to record on paper or on your cell phone so that you can input those into the survey at the end as well. Okay, you'll need that for attendance. We will also shortly be posting the slides and the calendar of our upcoming free events. We have one free event every month, one for ABA and one for psychology. So plenty of opportunities to learn more about both fields. All right. Next. Ariel. And okay. So I wanted to talk a little bit about us as a company. We do a webinar every month. We've been established since 2011, and we're comprised of psychologists, neuropsychologists, BCBAs, teachers, also RBTs, and we provide wraparound care, that's psychological testing, ABA, and educational services and tutoring, and we serve the greater New York City metro area. And we serve our DOE clients, insurance-based clients, and also private pay. Okay. Just a little bit more about MPG. Lakin's going to be talking more about all of these different opportunities. If you're interested in working for Manhattan Psychology Group, stick around for a couple minutes after Ariel speaks at 7:30, and Lakin will talk more about MPG. And then our vision. Manhattan Psychology Group's vision is to create a future where individuals and their families feel supported, connected, and empowered. And our mission is to provide multidisciplinary, integrated support for individuals and their families who experience mental health, behavioral, and educational challenges. And before further ado, Ariel Kornblum, who is a psychologist and BCBA, will be talking about ABA and CBT, cognitive behavior therapy, and how to best support children with autism and spectrum disorder. So Ariel has a lot of experience. She's our senior director at MPG, and she is both psychologist and BCBA, so she's going to give a really nice perspective of both fields and how they overlap. And I think this is going to be really great for those of us who want to improve our rapports with colleagues and professionals who are not BCBAs. And so this is an opportunity for everybody to learn a little bit more about another field. All right, there will be 3 polls. Like I said, we're going to be posting a link to the survey in the chat, and Ariel will also be answering questions at the end. So if you have any questions, please post those in the Q&A box. The chat box is now closed, but please do post any questions you may have in the Q&A.
Okay, ready to get started, right, Kristen?
Yes, we are.
Okay.
Right.
Thank you to everyone for coming tonight. I'm really thrilled to be here doing this talk. As Kristen said, I am a dually licensed psychologist, clinical psychologist, and licensed behavior analyst in New York. And I'm the senior clinical director of all the behavioral and educational services at MPG. My passion, my clinical passion, is really in the space in between ABA work and psychotherapy work. There's so much more crossover there than we think there is. And I think it's really important, particularly as BCBAs, like Kristen said, to be open to just the other colleagues we work with. So my first question, I just want to get a feel for the group, is have you ever worked with a learner who is also receiving or received a recommendation for cognitive behavioral therapy? Okay. Looks like we're about 50-50, which is really interesting. I've done this talk a couple of times before. This is the most split I've ever seen it. Most of the times, it's more no than it is yes. So I'm happy to have a bunch of clinicians here who have worked with learners who are receiving cognitive behavioral therapy. So before we get into it, I'm going to go really quickly through what ABA is and then what CBT is, and then we're going to talk about the intersection between the two and a bunch of different strategies to support our learners. So as many of us who are BCBAs know, there are 7 dimensions of ABA. The first is it's strictly applied. We are dealing with problems that have demonstrated social importance. Our goals, they are socially significant goals. It's behavioral. We are talking about observable and measurable behavior or reports of that behavior. It's analytic. We are looking for procedures that impact and impart effect on the behaviors that we're looking to impart change with. Our interventions are technological, meaning if I wrote an intervention, someone else who's here, a BCBA, should also be able to deliver that same intervention. We have a concrete and specific theoretical base. ABA is not a catch-all eclectic form of therapy. It is a science-based approach that has an identifiable scientific background and a theoretical base. Our interventions are effective. If they were not effective, they would not be the interventions that we use. We are looking to produce strong and socially important impact. And it's very important that our interventions result in behaviors that generalize. It wouldn't really make a lot of sense if we were teaching learners to engage in specific behavior with only their therapists and not with their parents or their teachers or with novel adults in the environment or peers. It's super important that what we are looking at, what we're looking to do, extends beyond the therapy that we are delivering. So what is CBT? So here you see the CBT triangle, and the CBT triangle is essentially the relationship between our thoughts, our feelings, and our behavior. And when I say feelings, that's the way your body feels. So identifiable things like, having butterflies in your stomach or palms getting sweaty, things like that. And behavior is observable, measurable behavior. So what I always do when I'm trying to probe this, let's say with a child, maybe 9, 10 years old, I'll ask, well, if I was a fly on the wall and you were experiencing anxiety, what would I see you doing? So we're looking at what is the observable behavior, right? If someone might say, well, when I'm anxious, I cry, right? Crying is something that I would be able to see. Or I get really angry and I hit people, right? We'll be able to see that. So the whole thing, the whole background of CBT is essentially that there is a relationship between all 3 of these things. They all impact each other. One doesn't come first and then the other one comes after. There's a lot in the history of psychology of other kinds of talk therapies that have sort of made the linear connection between thoughts and behaviors. And that's not what we're doing here. We're really talking about how all 3 and how they're interconnected. So there are adaptive and non-adaptive ways of reacting to a situation, and that is, per the CBT research, determined by how you think about them, how you process what is going on in your life, right? So, for example, everyone deals with stress differently. Everyone can deal with anger differently. So we're not as much talking about the emotion or the feeling and more about the response and what is happening with the way that the reactions are from the individual. So the goals of the therapy are to really get down into what are the core beliefs, right? What are the global maladaptive thoughts that the client is having that are impacting so many things in their lives, right? For example, if I have a negative automatic thought that someone is not nice to me at school, and let's say I'm a middle schooler, and I think someone is not nice to me, and all of a sudden I think, well, I'm worthless, no one will ever like me, right? It's a very global assessment, and that can really impact the way that I move through the world, the way I handle my emotions. So we're really trying to find those big, sweeping, negative automatic thoughts. And we're also looking to identify what are the body feelings that signal that I am having a really strong feeling or emotion, and what am I doing? Right? Like, what am I doing in that moment? If I'm feeling super anxious and super stressed out, what am I doing? So we're looking at all of those things before we actually start to intervene with each of them specifically. So we're going to do the second poll, and that one is, have you ever worked with a learner who was diagnosed or presented with a comorbid disorder? So they have maybe have an anxiety disorder, depression, any sort of internalizing disorder, in addition to having an ASD diagnosis. All right, so this is typically where we land. Right now we're at 90-10, 90 yes, 10% no, meaning that the vast majority of the people who are here tonight have worked with learners who also have a comorbid diagnosis. This is huge. This is actually, I'm going to go through the percentages, but so many of the learners that we work with and the clients who come to us with primary diagnoses of autism actually have a lot of comorbidities. And as clinicians, it's really our job to know and understand what that means. So for the purposes of tonight, we're going to talk about CBT for anxiety specifically. Anxiety tends to be the most highly diagnosed comorbidity for individuals with ASD. So what are our components? I'm going to put all three of them up here. We have three big ones. The first one is psychoeducation. The client has to know what is going on, right? This means sitting in session and talking about, well, what are the different parts of your brain that are at play? What's happening in your mind and in your body when you are experiencing this kind of anxiety, right? It's so hard to start working on something if the client is not able to identify what their symptoms are and how they are feeling, both with their thoughts, their feelings, and their behavior. And then we need to train for awareness, right? We need to establish that need for behavior change. So I always tell parents this, and I think it's the same thing whether there's ASD diagnoses at play or not. The average amount of time it takes an adult to come to therapy is about 6 months. In that 6-month time frame, they have been milling it over, thinking about it. Maybe they made an appointment, maybe they didn't. By the time an adult sits down in a therapist's office, they are absolutely ready to go. They are committed to making change. They have set aside the time. They are there to work, right? They understand that therapy is a lot of what you put into it. Kids in general don't get the same sort of process. For the most part, if you ask a kid why they're in your office, if they're 10, 11, 12 years old, the most common answer you'll hear is, well, my mom told me I needed to go, my dad told me I needed to come here, or my teacher said I needed to be here. Awareness training really gets us to the place where we can create that, that divide between here's where I am, and here's how that's impacting my day-to-day, and here's where I want to be. So these are the really important things that we're looking for when we're getting started for CBT for anxiety. The next thing is a huge part of it is exposure and response prevention. We will be working with our clients to identify what exactly makes them anxious. And we will develop subjective rating scales so they can tell us just how anxious they are in specific situations. And then over time, what we will be doing is gradually exposing them to these scenarios, starting from the bottom of the ladder, which is the least anxiety provoking, while simultaneously being able to manage the symptoms of the anxiety. So we start with, the low hanging fruit, the thing that makes them anxious, but not the most anxious. And what we'll do is expose them and also work with them on how to manage the anxiety. The best way to predict utilizing coping strategies in the future is if they're successful. So we really want to find a lot of success at the beginning when we're talking about anxiety treatment. This is where the hierarchy comes in. So we're developing a list of anxiety producing scenarios, ranked from the least to the most anxiety producing. We have to develop our effective coping strategies. This could be a lot of different relaxation strategies, breathing, progressive muscle relaxation. Every client will have something different that works, and every therapist should really have a great toolbox of strategies to offer their client that they can practice with them, they can role play, and they can have them try them out. CBT in general is conducted in office or telehealth, depending on the age of the client, weekly for about 45 minutes. Could be an hour, but for the most part, it's a once weekly treatment, a very traditional psychotherapeutic treatment. But therapists, when they're doing CBT, particularly for younger learners, they also need to be working with parents all the time to reinforce therapeutic strategies at home. I always tell parents this: behavior, anxiety, whatever it is, it doesn't occur in a vacuum. There is a real role for parents in adapting the environment so that their child can be set up for success. That doesn't mean giving in all the time or bulldozing everything that makes them anxious. It just means arranging the environment so that they can actually use what they're working on in therapy, which is so important. So, do ABA and CBT overlap? In a lot of ways, yes. And the primary reason why I put this training together in the first place is because I have been both through a doctoral program for psychology and a BCBA program. And I could never get over in the BCBA program. And now I've had my BCBA for a while, and I understand that things are definitely different now and moving in a different direction. But there was always this notion that we were never dealing with private events. We were never talking about anxiety or depression or any of these underlying things that, as a psychologist, I feel so wholeheartedly impact day-to-day functioning for so many individuals. Anxiety is something that every single one of us experiences at one point or another. Our goal is not to have zero anxiety. If we had zero anxiety, we wouldn't look both ways when we were crossing the street. We wouldn't really, anxiety is there to keep us alive. But sometimes the scales get tipped and we have too much anxiety. And I think the fact that when many of us trained to be BCBAs, we weren't really talking about those sorts of things. It doesn't mean that it's not in line with the science of behavior. It really is. And that is the reason why I put this together, because there is a lot of overlap there. And there are a lot of ways that the practice of CBT can inform a lot of behavioral work, ABA work, and also many ways in which ABA principles and the principles of the science of behavior can really inform cognitive behavioral therapy and actually are present there already. We just don't talk about them in ABA terms. So the beginning phases of any sort of therapy are the same for ABA and CBT. ABA, we call it pairing. CBT, we might call it rapport building or building a therapeutic alliance. But at the end of the day, we are looking to build a relationship with the client we are working with. Both of these therapies are focused on increasing day-to-day functioning. They are driven by socially significant goals, not here just to talk about things that are not meaningful to our clients. Many of the aspects of CBT are data-driven. When we talk about things like anxiety heart hierarchies and subjective units of measurement, we are collecting data. These are really important to CBT. We are focused on the generalizability of skills, right? If I have a client who is engaging, maybe they have selective mutism, and their anxiety is fueling the fact that they are not able to get their needs met in a classroom setting. But in session, they're able to tell me when they're feeling upset or they need to use the bathroom. That's not going to work, right? We need to generalize the skills outside of the office. ABCs, both have ABCs. They're different. But they both have ABCs. I have them here. The ABCs of behavior analysis are obviously antecedent, behavior, and consequence. For CBT, it's the activating event, okay? Like what happened could be the antecedents, kind of different ways of saying it, but it could also be like our go-to immediate thoughts or our initial interpretation of something that has happened. The B, behavior for ABA. For CBT, it's our beliefs. It's how we evaluate something that's happening. It's whether our core beliefs are rational or irrational. Are they serving us or are they not serving us? And then we have our consequences. Consequences are what immediately happens after from a behavioral perspective. From a CBT perspective, we're really looking at, well, it could be the behavior that happened right after, could be the emotion that we were feeling right after, but either way, it's what's happening after for both of them. Both of these therapies are solution-oriented. CBT is not psychoanalysis. It's not where you sit and you talk a lot about, your childhood, and it's basically talk therapy. CBT has a homework aspect to it. It has very structured sessions, and the goal is to impart change, and specifically to impart behavioral change. Both of these therapies are highly structured. Sometimes, depending on who the client is and where they're at and what they're working on, they might look very, very similar, just with different times, maybe in different locations. So I want to go into the ASD and the comorbidities. Is this where we get the code, Kristen?
There'll be a code page.
Okay. All right.
I'll just double check.
So ASD and comorbidity. So like I said before, the prevalence of anxiety disorders within the autistic population is reported to be somewhere between 11 and 84%. What's really important to know here is with ASD, clearly we are talking about individuals with diagnoses of level 1, level 2, or level 3. And many of the clients that we work with are unable to tell us about their feelings and their thoughts, right? So we're going based on what we can observe or what they are able to communicate to us. That is why the range is so big. Any sort of traditional rating scale measure of anxiety is unlikely to pick up all of the anxiety that's present within the autistic population. So we, as clinicians, we need to understand what we're looking for, right? As BCBAs, we've all said probably hundreds and hundreds of times that behavior is communication. Behavior doesn't happen in a vacuum. If something is going on, this is a client trying to tell us something. It is our job and it is imperative as clinicians that we are working tirelessly to figure out what that is. So we could have somatic complaints, stomach hurts, I have a headache, I'm tired, some of that stuff, maybe school refusal-ish, avoidance, I don't want to do it, right? Avoidance can look like vocalizing, I don't want to do it. It could look like body dropping when asked to do something that they maybe don't want to do. We have a lot of worrying. Excessive worrying can lead to a very, very, very strong rigidity to specific routines and structure. So it is really important that BCBAs are very, very schooled on what anxiety disorders can look like, because it is likely, I mean, if we go with the 84%, it's more likely than not than the client in front of you also is struggling with anxiety in addition to autism. So the occurrence of anxiety has been found to be higher than typically developing children. Now, again, you take this with a grain of salt because we do not have specific rating scales. It's hard to really bank on that data. But for the purposes of this conversation, and really for the purposes in which I practice, and I know a lot of others practice, there is the assumption that, an autistic population, the client in front of us, is more likely to be struggling with comorbid anxiety than a learner who comes or a client that comes into the office that does not have that same autism diagnosis. When compared with other at-risk groups, so clients who have clinical diagnoses of conduct disorder, oppositional defiant disorder, learning disabilities, children with autism, again, significantly more likely to be diagnosed with an anxiety disorder or have more intense anxiety symptoms. Anxiety in children, in autistic children, is thought to exacerbate the symptoms of ASD, may result in decreased independence and daily living skills and increased behavioral challenges. So I wrote noncompliance here, not because it's a term that I utilize frequently, but because that is something you might hear from a stakeholder. You might hear it from a school, or you might hear it from a parent. And when you hear that, it should be a big, big, big sign to think about anxiety. Anxiety in general in the school age population, like pre-K through 5, looks like behavioral challenges. More often than not, the initial referral that might come from a parent or come from a school is of really, really challenging behavior, aggression, destruction, a lot of difficulty transitioning, and then that keyword non-compliance, which is what people will really come and say, this is what's going on. ABA and CBT can be combined as an effective intervention for comorbid disorders. So if you have clients and who are diagnosed with autism and also diagnosed with anxiety or depression, you can combine these two modalities to have an effective intervention. There are specific things that we need to talk about first, though, because it's not a great fit for everyone. So the research shows us that utilizing the principles of behavior analysis can enhance and support the components of CBT. I alluded to this before, but it's really something important to think about. If you are going to be using this, likely what you are going to be using is a strategy that comes out of the CBT world. And what you are doing is adjusting it using the science of behavior analysis. The CBT is intended to treat the comorbidities, anxiety, depression, and anger. It is not a direct treatment for autism, although effective treatment for comorbidities may have an impact on ASD symptoms as well. But CBT is not a treatment for autism specifically. The research also supports that modifications of CBT can assist in management of symptoms of anxiety, as well as in the development of social and daily living skills. I'm going to go back to this and look at the emerging research again. At the time I wrote this, there was a lot of emerging research on identifying the specific mechanisms of behavior change so that we could start to maybe standardize some of these therapies. I will say that the real intersection of ABA and psychotherapy is really in that acceptance and commitment therapy space. So if you are interested in doing more of this kind of work, I would also really recommend looking into ACT because it is well within the scope of a BCBA and something that can really also treat a lot of these comorbidities. So who's a good candidate? Because like I said before, it's not going to be everyone. So children diagnosed with level 1 ASD per the DSM. So that is what some people might refer to as high functioning autism. I refer to that as a low support need. So that is a client who more likely than not is testing at about an average to above average cognitive ability, is vocal in either a integrated or mainstream classroom setting. They have functional communication skills. They also meet criteria for an anxiety disorder, depression, or clinically significant anger. And they are able to, like I said, they're in a mainstream or an integrated school setting. This is our first code. It's visual. So you have to write it down. This is the first one. There's going to be 2. So I'm going to give everyone 10 more seconds. Okay. It's visual, VISUAL. So we're going to dive a little bit now, this is really the meat of this presentation into, well, what are the strategies? Let's say you have a client who meets all of that criteria I talked about. How can you start to do some of this work? So we're going to go through 8 of them. And many of them you've seen before, but I really want to talk about them within the context of cognitive behavioral therapy. The first is the use of visual aids. This is really important. The use of visual aids can support and supplement really any sort of supplemental therapy. BCBs, of course, and ABA sessions, we use visual aids all the time, but utilization of a visual aid for a session schedule for speech, OT, PT, counseling, therapy is so wonderful for those therapists to structure their sessions and a place where they can really take the science of behavior analysis and make it work for their discipline. So utilizing a schedule, let's go through parts of the session. It can look, it can look 100 different ways, as we all know. You can do a board like this. In my office, for most of my clients, I just have a whiteboard. I'll write things out. If that's where they are at, I'll have them write it out. There are lots of different ways to do a session schedule. It does not need to be fancy or laminated or anything that takes a whole lot of time to put together. Same for utilizing a timer. I am particular to that timer that has, when you turn it, it's all red, and then the red gets smaller and smaller as the time is running out. I think it's a great visual on a visual. Other things that are great are, in my house, we have an Alexa in every room. I'll use that for a timer. It has a manual countdown on it. Also really helpful. First then boards, so simple and so effective. Again, part of what makes ABA so wonderful is the pragmatism with it. And sometimes it's these very simple things that really make all the difference. So first then boards, token boards, choice boards, any sort of visual aid. It's going to depend on the age and the interests of your client, but overall, we're looking for any way to supplement the work that we are doing and to set the session up, right, to create that structure. Incorporating child-specific interests. So I said this before, I'm going to say it again. Pairing, rapport building, all the research. This is actually one of the most favorite research things that I've ever read in my whole time in graduate school. And there was a whole article in the New York Times again about it last week. I don't know if anyone read it, but it's this idea that really what determines therapeutic outcome is not the training of the individual or the modality they are using. And I'm talking about like psychotherapy, not about ABA specifically. It's about the rapport. There is nothing more important than investing time in relationships and pairing with the client who's in front of you. I always prep parents. It might take a really long time to build a relationship. That's okay. As a therapist, you really need to be upfront about that because parents will start expecting things to happen. And if you don't feel like you're there yet, then you're not there yet. You're the expert in the room. When working with children, who have a diagnosis of ASD, and we're talking about those level 1 kiddos, it might take more time. You might have to get way more specific about your interests, right? You might have to learn about, trains or the subway, or, in my experience, I've learned about elevators and how elevators are built, right? It might take a lot more work to do it, but you have to. It is the most important thing that you're going to do. At the beginning, it's okay. Let the clients talk about the thing that they love to talk about. You want to be interested in that. Regardless if it's not interesting to you at all, you have to be there to create the relationship. And it's not just at the beginning. Every single time you see that client, whether that's once a week, 3 times a week, 4 times a week, 5 times a week, even if you're seeing that kid every day, you need to do some rapport building at the beginning of each session. It is so important to not lose sight of that. If you have a client, you go to a client's house or a client comes into your office and they are not happy to be there, there is nothing therapeutic that you can do other than work on your relationship. It is so important to invest and reinvest over and over again. Utilize the specific interests when you are structuring your session. So maybe your token board is a train, right? You add trains to a train chat for every 5 minutes. Maybe you're watching a preferred video if that's something that can work. You have to be open to, clearly you're going to do a reinforcer inventory and do it again and again so that you can really incorporate those specific interests into structuring the session. The third is social skills development. Incorporating social skills development, even if that's not the primary reason that client is in your office, chances are it's going to be something socially significant and important for them to work with. And children with autism, they thrive on predictability, structure, rules, and routines. Actually, that applies to really all kids. I will often tell parents, like, have you ever been in a 1st grade classroom, a 2nd grade classroom? It's kind of boring. They do the same thing every day. They do a morning routine, but every kid, when they walk in there, they know what to expect. And that is so, so, so important for managing anxiety. It is one of my biggest recommendations for parents who are doing parent training, if they have a child who's struggling with anxiety, is to infuse as much predictability as humanly possible. Because anxiety, it flourishes and it grows in the unknown. So anything that they don't know about, they will start to feel more and more anxious about. Social situations are absolutely one of them. They are complex, unpredictable. They are really hard to develop rules and routines around, and they can be associated with a lot of emotional dysregulation. So we need to do the best job we can to identify concrete contextual clues that allow children to identify the rules of a social situation. That might be utilizing social stories or role playing or video modeling. I love the one of creating a comic strip together. That might mean if you're a therapist and you have a client coming into your office, that you are turning right around and walking out of your office and taking that child to the playground. That might be what you're working on, because we BCBAs, we love to do stuff in natural environment. 4th is increased parent participation. This is non-negotiable. If you have a child in therapy with you, you need parents to be involved. If parents are not involved, the skills will have such a harder time generalizing. They will have such a more difficult trajectory in terms of easing the anxiety that the client maybe came in with. And repetition is key. We can work on great things in session with a client, but if they don't have the opportunities to work on those skills, to generalize those skills outside of therapy, we're not going to see a ton of progress. So parents need to know. Earlier, I talked about a client's receiving psychoeducation at the beginning of their therapy journey. Same for parents. They need to understand and be aware of what is going on with their child and the way that they can support them at home, right? Things like identifying feelings, utilizing those specific coping strategies. Let's say you come up with a great deep breathing technique with your client in the office. Parent needs to know about that so that they can practice it at home. If you develop a social story in session or outside of session and send it to a parent, it's up to the parent to be exposing their child to that and be reading it to them. Looking to shows and movies that highlight feelings, emotions, navigating complex social situations. If you are developing a goal or a behavior chart, that's going to be on parents and caregivers to really follow through with. Parent management training is a specific kind of therapy, and you could work on that with coping with anxiety. I meant to add to this, but I forgot earlier, we have a newer parent-only form of therapy called SPACE, which is supportive parenting for anxious childhood emotions. And that is where the client doesn't come see you at all, and you work directly with the parent. And the research is phenomenal on that, really reducing anxious symptoms among clients. And there is really great data on that for comorbidity with the autistic population as well. Social stories. So I know social stories don't have like a huge plethora of data to support their effectiveness, but I think they're a useful tool and they can be really utilized effectively in CBT. When we're talking that psychoeducation about linking our thoughts, our feelings, and our behaviors, that can sort of be difficult for younger clients to understand. And through a social story, we can really make that a little bit more real, a little bit easier to access and understand. Same with the awareness of emotions, just knowing how we're feeling, identifying emotions in other people. We can utilize social stories to break down and do task analyses of relaxation techniques or coping strategies, developing understanding of what behavior might be expected and what kind of behavior might be unexpected in specific social situations. And that pulls directly from the social thinking curriculum, which I'm going to mention later. And you see here, I put up like just a very brief social story, but here's what I can do when I feel angry. And that's a pretty easy thing for a client to create in session with you, or for you to create to send to parents, teachers, any other caregiver. So contextualizing emotions. So we want to really work with our clients to be able to have awareness of their emotions. So creating a book with pictures that elicit specific emotions, right? So this is my happy book, and here's a book of all the things that may make me feel happy. Sense, taste, music, all great ways to make a connection to emotion, specifically awareness of emotion. I think that it's one of these things where lots of adults, maybe not the people who are in this kind of a field, but lots of adults will assume that children have a lot of awareness of emotions that they may not have. It's actually something that we need to teach in therapy. So it's a multimodal approach. We're looking at all of these different ways of teaching awareness of emotions. So we can utilize video modeling, pictures of other people, can utilize social stories and matching programs to identify emotions in others. And then we have concrete tools to describe the intensity of our emotions. Things like a thermometer or ruler, right? We need to actually direct teach emotional vocabulary, right? Feeling anxious indicates, well, to me at least, a more severe and intense feeling than feeling stressed out does. And that is something that we can teach to our clients on on different level depending on where they're at. The concrete coping strategies. This is a critical part of CBT. It's an easy thing to work on and to teach, and is something that we need to be doing very close to the beginning of initiating a therapeutic relationship. So we can teach them via task analysis, super easy to do it that way. A lot of doing it together and role playing it and breaking it down and doing it and practicing it. The great thing about all of these things is they're super quick to do. So even in a 45-minute hour session, you could definitely get like 3-4 opportunities to practice all of these things. And it's a great thing to teach to parents. Parents will be able to learn these things really quickly too. It's one of those really low effort things that can have a really great impact if it is generalized and shared and practiced enough. Progressive muscle relaxation is one of my favorite things to do, for myself when I'm feeling anxious. I would highly encourage everyone to do it. If you have an Alexa or anything like that in your room, you could just say, play me a progressive muscle relaxation script. It is really going through every part of your body and systematically tensing and releasing your muscles, which allows us to relax. It's a little bit longer than these other things. There is a really wonderful on YouTube, a child adaptation of it, has great graphics. Lots of kids really like that. Again, this is one of the things that gives families and caregivers a real concrete thing to work on with the client, with the child. So alternate modes of communication. It might be really hard for a level 1 autistic client to talk with you about their emotions. There are so many ways to communicate emotions, and it is our job as the clinician to really find what's going to work best for our clients. So I put here like a little prompt for a journal. This one is great. It has drawing or writing, which is wonderful. There are tons of apps now that can facilitate communication, feelings journals, pretend play, coloring. Again, you are really looking at a very multimodal approach to getting in there and understanding what's going on. Like I said, the traditional rating scales, they're not going to really get at, what's really going on. And it might give us a jumping off point for therapy, but we need a little bit more. Okay, so the third poll is, which of the 8 strategies are you most likely to use? There it is. I'm going to stop it. So use of visual aids is going to be the most, followed by incorporating child-specific interest, social skills development, parent participation, social stories, and the last one is contextualizing emotions. I think that for a BCBA population, this is the answer I always get. Use of visual aids, I think, is the easiest thing to incorporate, and it doesn't, it can be any client, and you can incorporate visual aids in an effective way, and a little bit goes a long way. So absolutely. Here's the second code. It's coping, COPING. I'm going to leave it up for another 10 seconds. Okay, so these manuals are really good ones. I use them all the time. They do a fantastic job of making a lot of this stuff really meaningful for our clients, particularly those who have the comorbid diagnosis of ASD and anxiety. The zones of regulation, Superflex is my favorite. It's a social thinking curriculum. It dives into so much of that expected and unexpected, unwritten social rules. The great thing about Superflex is lots of kids really like him. He is he's a superhero who basically combats a lot of things that are holding him back. So in addition to being very socially based, it also dives in a lot into awareness of feelings and social mapping and all this stuff that is really powerful for awareness. The zones and ruler are fairly similar in that they use color, and the 5.2, they all use color coding to increase that awareness of this, the intensity of an emotion. And that can be really, really helpful when working on awareness and having clients identify how they are feeling and how intense that feeling is. Because again, it's really totally typical to feel anxious every once in a while, but it's not typical to feel super duper anxious, like a 10 out of 10 for days on end. I would encourage checking all of these out. So we have about 10 minutes left. I'm going to jump into the Q&A. I saw a few people raise their hand. If you raised your hand and you had a question, just do me a favor and type it into the Q&A because I'm going to answer questions there. Okay, so the first one, I'm going to read them first. If anxiety overwhelmingly possesses an escape dimension, doesn't challenging, distorted thoughts actually serve to maintain the anxiety through temporary avoidance and escape? So it's a really interesting question. So you're not going to be challenging in the moment. Your challenging is happening in session when they're evoking their thoughts about the situation, and they're telling you about, here's my thought process, here's what's going on when I'm avoiding something. And you are challenging it in that moment, having them practice it, a rational thought to replace the irrational thought. And then they need to practice that in real time with something that is anxiety provoking. Next one is, can you use CBT with littles like 3 to 4? I don't really think so. They're a little bit young to understand. In general, I usually look to about age 7 to be like kind of the cutoff here. So rapport building in psychology is the next question. What did you say that I called it? So it can be rapport building or a therapeutic alliance. The next one. Oh, that's cool. Carrie said the company I work for created a program that uses CBT and ABA together called the Modified Cognitive Behavior Intervention. I would love to hear more about that. If you can, grab my email, I would love to hear more about that. I recently heard someone speak about trauma and autism diagnoses. The speaker noted that the symptoms, behaviors of trauma can mimic qualifications of an ASD diagnosis. What are your thoughts on this, and have you heard? What is driving my interest in CBT with conjunction with ABA is I feel that there are underlying needs that can't be addressed with ABA alone, such as private events. So I would agree with you on the whole back end of that. That is the reason that I'm doing this. That is the therapy I practice. I always felt like there was something to be missing with the ABA, like the BCBA coursework I got, specifically in the notion that we were absolutely not talking about private events. And I've always felt like the psychotherapy techniques that I've learned, they benefit greatly by being beefed up by some behavioral, like some real behavioral foundation. As far as the trauma and the symptoms and behavior, I don't really have thoughts on it as far as diagnosis is concerned, but I have a lot of thoughts on it as far as therapy is concerned. So in general, when you are treating someone with a diagnosis of autism, coming at it from a trauma assumed perspective is super important. I think it might take a really long time to tease out what symptoms are a result of trauma or what are coming from a diagnosis. Remember, diagnoses are not like blood tests, right? They come from standardized assessments, but they're not the end all be all, and they can change. So I think that if you are treating an individual, an autistic individual, coming at it from a trauma assumed and trauma informed perspective is super important, because the fact is you don't know. Many learners that I've had, I suspect, have an anxiety. Oh no. Disorder as well, only have an ASD diagnosis as is the first one given. How have your learners received this dual diagnosis? That is a fantastic question. And I think part of the reason I put the stats up there, 11 to 84%, is that in general, you might, more often than not, you will get a client come in with ASD as the one and only diagnosis. And it's the primary because it's the driver for insurance coverage for therapy and things like that. If you suspect that something more is going on and you are not a clinician who is able to diagnose, I would talk with the parents, talk with your center or wherever you are about doing a reassessment and including anxiety measures specifically in there, or going back into the raw data of their assessment, because it could have popped up and the clinician, the testing clinician just sort of included it as the ASD diagnosis and not something comorbid. But they're really the only way is to go for another evaluation. Next question. Would you not use this for home or clinic-based kiddos? You could use it for anyone that you think would benefit from it. This is a really good question. What are some of the key differences between CBT and ACT? This is a very long answer, so I don't want to give something short, because I think that deserves a much more time than we have now. There are a lot of differences. So I would encourage you, if you are thinking about both of these kinds of therapies, to really look into them. Their foundational philosophy is completely different. So it's really important to know about both. What is it called when training only the parents to help their children cope with anxiety? It's called SPACE, Supportive Parenting for Anxious Childhood Emotions. You can find some information about it on our website, but it's out of the Yale Parenting Center. I'm gonna try and go through. So would you only suggest CBT for a level 1 ASD? I mean, it depends on how confident you are with the levels of the diagnosis. I wouldn't say it's like an end all be all, but I would really look to, the functional communication being there. It's a talk-based therapy primarily, so you want to make sure that you feel like you're able to do that. But no, it doesn't necessarily just need to be for one. What age or cognitive level is a prereq to beginning CBT? Around age 7, and you're looking at average to above average cognitive ability. Again, you're taking that with a grain of salt, because it's based on testing that might not accurately get at IQ. I can Google I don't have the PMR YouTube video someone asked for, but I can send it later. Are there specific trainings I can do for CBT? There are. I will say that, like, doing CBT itself, you want to be very careful about scope if you're a BCBA. That being said, ACT is well within the scope for BCBAs. What ages do you think Superflex is appropriate for? Superflex goes all the way down for younger kids, like kindergarten and first grade, and I wouldn't use it past like middle school. Are DBT and CBT the same thing? No. DBT is dialectical behavior therapy. It's also a different modality than CBT. How can we set goals for ABA, adding emotions and other internal processes? Fantastic question. So in terms of, like, let's say you're working for an agency with an it's an insurance company, and you need to write an objective, measurable goal. You can add things about independent utilization of coping strategies. You can put something in there about reducing symptoms of anxiety and get specific about what they are. As long as you have some quantitative, stuff to back it up, I think that's the best way to put it in. What word choice would you use instead of non-compliance? I don't really use it at all. I don't think it's a good describer of behavior. Non-compliance can look like a zillion different things. If I'm non-compliant and I'm body dropping, the behavior is not non-compliance, it's body dropping. So I think it's sort of the negative, and that's not observable to me. If you say, oh, what's the child is non-compliant, I don't really know what that means. Are they yelling no at you? Are they throwing stuff at you? Are they walking out of the room? What is it? Are BCBAs allowed to treat someone who only needs CBT, or must it be utilized with ABA for a client with autism? BCBAs cannot do CBT exclusively. No, it's outside the scope. But there are certainly many individuals diagnosed with autism who would benefit from only CBT. The next question is the same thing. Who should be doing CBT? Yes, licensed counselors, licensed social workers, licensed psychologists, mental health counselors. Do you have suggestions for children who are extremely resistant to talking about emotion, even if you have great rapport? Yes, just keep building, just keep hanging out and building rapport. You have to be that trusted person. It could take a year, in my experience. Is SPACE only offered through MPG? No, you can go on the SPACE website and there is a directory of all clinicians who are trained in SPACE. I am one of them. Many of the clinicians at MPG are, but there are tons of them all over the country. Does a lack of theory of mind that we often see in our clients with ASD impact our ability to use CBT? Should we be assessing that first? It does impact, and that's why we have to teach things more explicitly, like I was talking about. We don't assume that identification of emotions is there or comes easily. That means we have to teach things a lot more systematically and explicitly. We only have a couple of minutes, so let me see. Is there a CBT training? Yeah, there's lots of CBT trainings out there. I would Google it. What are your thoughts on the role of accommodations caregivers end up doing that reinforces anxiety? How relevant is this with comorbid ASD and anxiety? It's extraordinarily relevant. I would look up the difference between enabling and accommodating. You can accommodate and set your child or client up for success without enabling or reinforcing the anxiety. I think this is a prime example of one of those spaces where the behaviorists in us want to say that accommodation means reinforcing it, but that's not really what that is. What we're doing is supporting our clients. So I think this is what's slowly breaking down that rigidity and the behavioral stuff that we were all taught in our BCBA programs. And I would think about accommodation not so much as a negative word, but really something more positive. If a BCBA cross trains in trauma and CBT, can you provide CBT? Then you can certainly incorporate, like the strategies I talked about, you can incorporate them, but a BCBA cannot say they are practicing cognitive behavioral therapy. I'm going to end on this one because it's something I get all the time. How do you get around a child who always responds in the positive when you asked about their emotions, despite knowing that their week or days in between sessions were not great? This happens all the time. Even if you know, you can't tell them you know, you still need to be that solid rock rapport for them. It just, even though it sort of pains to think about it this way, the truth is they don't feel comfortable enough to tell you. So you're not there yet. This is coming from someone when it happens to them all the time. It's part of the work. When they start opening up to you, particularly a kid that's really closed off, that's when you know you're really getting somewhere. Yeah, someone wrote accommodation is more proactive, so it's not reinforcing. Thank you. And that's it. If you want to learn more about working with us at MPG, Lakin is going to put a link in the chat to go to another Zoom room where you can hear a little bit more about the opportunities. Thank you all for coming. I hope you enjoyed. I certainly enjoy always talking about this topic. So have a great night.
Thank you, Ariel. So for those